Hi, my name is Dr. Stephanie Pearce. I'm a pediatric orthopedic surgeon and current sports medicine fellow here at the Stedman Clinic in Vail, Colorado. Dr. Millet and I will be talking today about return to sports in the COVID era, a community approach for youth athletes. These are our disclosures. COVID-19 is an ever-changing situation, as we all know. Most recent data has shown that worldwide there's been 143 million cases, 3 million deaths, and in the U.S., 31.5 million cases with over 560,000 deaths. So it's definitely an impact that's occurring to all of us. 1 in 5 hospitalized COVID patients have cardiac or clotting complications, and that includes sudden cardiac arrest and pulmonary embolism. So this shows how impactful and life-threatening COVID-19 can be. What's the importance to sports? So safe and healthy return for athletes after a COVID-19 exposure or infection is critical. Guidelines and recommendations continue to change, and currently there's no standardized return to sport protocol that exists. Some questions that we have in the athletic realm is what sports and what athletes have a higher risk after COVID-19? How do vaccines play a role in sports? What should be done if an athlete contracts COVID-19? And how can we safely return these athletes to sport? So the CDC has looked at risk factors in sports for contracting COVID-19, and they've seen that increased risk occurs with close contact sports, higher intensity, larger team size, longer playing time, especially within 6 feet distance, indoor activities, increased travel. And you can see here the basketball game has no visitors. Many arenas and stadiums have done the same by decreasing the non-essential visitors, spectators, and volunteers, and this is at all levels. Shared equipment and gear is also another risk factor, and poor social distancing on and off the field has really seen to make a difference. Higher risk of severe COVID-19 illness in athletes occurs when patients have underlying medical conditions, such as these listed here. And what happens if an athlete does get COVID? So if a patient has symptoms, they should get tested right away. If they have a positive test, they need to self-isolate and monitor these symptoms closely. Determine the close contacts is the very next step. Contact tracing is very important to help our community load of COVID-19 and minimizing this and the effects. So notifying league organizers, staff, and parents is very important, and all close contacts will then need to quarantine. When we talk about COVID in the athlete's heart, we just heard a great session on that. An article came out in January showing 26 athletes with a mean of 19 and a half years, really hitting that high school and collegiate athlete population. All patients underwent an EKG, echocardiogram, as well as a cardiac MRI, and 15% were found to have findings of myocarditis. Additionally, 30% were found to have evidence of a prior myocardial injury. The most interesting thing about this article is that the EKG and the echo actually came back within normal ranges, and it was the cardiac MRI was the only thing that was able to identify these injuries and these risks. Another really important concept to explore is called Multisystem Inflammatory Syndrome in Children, or MIS-C. It is a post-viral condition in children that happens after COVID-19 exposure or contraction, and it's similar to Kawasaki's disease in the post-viral element, where it can be extremely severe in nature, and it inflames multiple organs throughout the child's body. This has been seen in almost 3,200 cases in the U.S., and 36 deaths have come from patients diagnosed with MIS-C. One institution showed data with 50 children that were diagnosed with MIS-C. A quarter of them only had positive PCR tests for COVID. However, 98% of them had positive COVID antibodies. What this tells us is that most likely the post-infection inflammation tends to be more significant than the viral load itself. So how do we diagnose this? It's in individuals less than 21 years of age with fever, Inflammation labs are increased, such as CRP, ESR. Cardiac markers are another really important thing to follow. Severe illness requiring hospitalization, and then 2 or more organ systems are involved. There's also should be no evidence of another plausible diagnosis, and they should have either a positive COVID test or exposure within the last 4 weeks. And so this is what's really important, is that and here you can see on the graph there is the daily MIS-C diagnosis levels, and then you can see the COVID-19 levels, and they follow closely. And so a lot of these children are asymptomatic or mildly symptomatic, and then within the next 4-week period after their exposure to COVID-19, they get severely ill, so ill that they need ICU care and extreme high levels to be able to support them through this post-viral process. So how do we treat them? It's supportive care. IV fluids, pressors are really important. IVIG and steroids have seen to help minimize symptoms and help decrease the duration. Respiratory support, being on ventilators, is a big component to this, and some patients get so severe that they actually need help with ECMO or extracorporeal membrane breathing to help give their heart a break, and so then they can still perfuse and transfuse the oxygen throughout their body. So overall, it's very important to monitor these pediatric athletes and initiate treatment as soon as possible, and that begins when they're on the field after their exposure, returning back to play, and they're still having fatigue or they're still not able to catch their breath. That's usually how this starts, and then it can start to propagate from there. So what does the NCAA say on return to sport? Currently, if someone is a positive COVID test but no or mild symptoms or even a moderate illness, then they need to have a limitation in exercise, 10 days for the mild to no symptom patients and 14 days or longer for the moderate illness patients. And then always the symptoms will help guide. So if symptoms persist beyond that time, it's important to still delay exercise restart until those resolve. Also consider getting EKG or echocardiogram and potentially further workup if needed, depending on symptoms. For our severe patients, our hospitalized patients, it's recommended for a full medical evaluation as well as a cardiac consultation, and consider doing that cardiac MRI so that we can see if there's going to be some of the myocardial edema and other inflammatory processes. Locally, what are we doing here? So our return to sport guidelines for Ski and Snowboard Club Vail has been an elaborate collaboration between community members, schools, orthopedic surgeons, cardiologists, and pediatricians. It's evolved according to CDC state and local guidelines, and it has expanded now to include Aspen Valley Ski and Snowboard Club, Battle Mountain High School, Eagle Valley High School, and Aspen Valley High School. This is what it looks like. This is our current guidelines. And so when we look overall, the big thing to kind of take away is that there is an initial action phase, exercise guidance depending on symptoms, medical clearance required for positive tests as needed for exposures, and then graduated return to play. And we'll go through all the detail. So what are the steps to return after positive test? First is completing the daily symptoms form, and we'll see what that looks like in just a minute. Exercise guidance is going to be based on symptomatic versus asymptomatic individuals and their duration of symptoms. Medical clearance is a requirement for our athletes, and a graduated return to play to make sure that they're coming in safely and they don't have a recurrence of symptoms. Ready? So the daily symptom form, every day the athletes are going to track their temperature, their symptoms, and at day 10 they will then be required to fill out an IPRRS form to help determine their confidence in returning to sport and help minimize injury. This process helps assist providers in working through the algorithm to safe return to play. Here is the checklist, and so you can see it's symptoms as simple as headache, nausea, vomiting, diarrhea, moving towards loss of smell, loss of taste, and then even including irregular heartbeats, chest pain, chest fullness, feeling like they're going to faint, difficulty breathing, etc. So the full range of symptoms are important to keep an eye on, from as simple to severe. Once they hit that day 10 mark, they're going to be required to fill out this IPRRS scale, which is the Injury Psychological Readiness to Return to Sport scale. And so it was developed by our athletic training colleagues and was completed with a Delphi method with an expert panel that created a 6-item questionnaire with a scale from 0 to 60. And the results from this have shown that scores less than 50 should really help us reconsider whether or not we should allow that athlete to return to sport. Their confidence level to play is not there, and that may be evidence of still having symptoms, whether or not they are able to elicit that, or that the lack of confidence itself is going to increase their risk for injury. Exercise guidance. So this is based on symptoms. Asymptomatic individuals are going to have no exercise for 10 days after their exposure. When athletes have mild symptoms, they'll have no exercise for a minimum of 10 days from their symptom onset, even if symptoms last 2 days, and then a minimum of 7 days after their symptoms resolve. So if a patient has symptoms for 4 days from their symptom onset, then they will be required an additional 7 days after that, bringing them to an 11-day total period. For the moderate into severe symptomatic patients and athletes, no exercise is allowed to begin for 14 days from symptom onset, and if those symptoms continue past the initial period, that they still need to have 14 days after their symptom resolution without exercise. So if they have 7 days of symptoms and then they start to resolve, they still will be out for 3 total weeks for their resolution before beginning their graduated return to play. Medical clearance is a requirement for our athletes. Clearance form and physical must be on file prior to beginning their gradual return to play, and we should consider cardiac testing if previously tested positive, and especially in cases of cardiac symptoms, as well as hospitalization. We've seen that 1 in 5 hospitalizations have cardiac symptoms and disease processes included, and so making sure we protect the heart and our athletes that are going to be pushing cardiac function to the limit is critical. Here's our graduated return to play. Overarching theme here is very similar to the post-concussive return to play algorithm. So anytime a symptom begins during this graduated return to play, that athlete will stay on that current stage until they are fully symptom-free for 24 hours, and then will continue on to progress as they are able. So light activity is the first stage. It's a minimum 2-day requirement. It's aimed to gradually increase their heart rate. And so this is going to be less than 15 minutes of a light activity, such as walking, jogging, stationary cycling. The goal is to record their resting heart rate. It should be less than 70% of their maximum heart rate during the exercise period. Their rate of perceived exertion should be less than 7 out of 10, and their oxygen saturation should be maintained above 92% throughout the course. As we move forward, simple movement activities and beginning sport-specific motions is a 1-day requirement. We start increasing the time and increasing the heart rate levels and really start assessing for symptoms. So less than 30 minutes of activities instead of 15, and now we're going to bump up the max heart rate allowable to less than 80% and a less than 8 out of 10 rate of perceived exertion. 92% oxygen saturation is still going to be critical. Once they pass that level, we'll go into more complex training activities and we'll increase the time and duration of these activities. So less than 45 minutes of sport-specific drills. We can add in light resistance training, still maintaining the same level of heart rate max and exertion maximums. Then we go into a 2-day requirement of normal training activities, and it's clear that this is not return to sport. This is not free reign. You're still limited by time and still limited by the heart rate levels. So it's less than an hour of the activities that they're normally going to be doing. For our ski and snowboard athletes, they're going to be back on the mountain, but it's only going to be for an hour. And then we still need to be monitoring symptoms very closely. Once they do well with this, will allow for resume full activity. And so training intensity will increase, confidence and functional skills will be assessed, and at the there will not be necessarily a heart rate limitation, but we're still going to be monitoring very closely for any signs of return of symptoms. And so this still is a reason to potentially delay. If we go to this level, they start having more fatigue, they start having headaches, they start having difficulty breathing or chest pain, then we back down to a limited time frame of 60 minutes. So what has our data shown in our athletes? So our ski and snowboard club athletes had 19 cases and 1 false positive. 18 of these were athletes and 1 was a coach, ranging from 9 to 20 years old, 13 males and 6 females. You can see that the majority of these patients were mildly symptomatic and were severe. 4 athletes had prolonged return to skiing, and all of these athletes symptoms were due to fatigue. So this is a very easy one to kind of brush off, but is very important, especially in terms of cardiac function. 1 athlete reported continued decreased smell and taste symptoms, and that is one that is the only exception to the symptom rule, that continued decreased smell and decreased taste will not hold an athlete from progressing to return to play, but it's still something to kind of keep an eye on and monitor. No other complications caused a prolonged return, and all cardiac screens were fortunately negative. For our high school data, we saw 27 athletes had a COVID positive test, 16 males and 11 females. This is interesting. It's the distribution of cases by sport. And so you can see here kind of remembering what the CDC risk factors are for increased COVID contracture and exposure. We see football and basketball as the 2 highest, both basketball, volleyball being indoor sports, football usually being outdoor sport, but having a much larger number of team members. And so close sideline contact as well as duration of play plays a role into this. Wrestling actually has a lot of these risk factors that the CDC mentioned, and here you can see in our patients only 1 case was tested positive for COVID, and that despite having close contact and in a closed indoor environment, there are a lot less team members on the wrestling team, and so these teams did an excellent job of keeping the exposure risk down. Most of these were mild, similar to our ski and snowboard club athletes, and the outcomes that we saw, 3 athletes had prolonged return to sport due to return of symptoms. 1 did not return to competition because of an ACL surgery, and 1 team had to quarantine in total due to a positive exposure, but still were able to keep the number of cases down. All cardiac screens, once again, were fortunately negative. In summary, athletes returning post-COVID-19 should have a basic cardiac screen. They should also have an additional workup if they have a severe illness or they're having specific cardiac type symptoms. Graduated return to play is the best way to safely return our athletes back to their sports, and we should always be considering national, state, and local rules and regulations when we are the ones developing the guidelines. And so these are ever evolving. We need to stay current. It's our responsibility, especially as we put these guidelines out, and also as we are working with the athletes to follow the guidelines closely. In conclusion, minimal evidence exists on complications in youth athletes following COVID-19. More research is needed on both athletic populations and youth populations, and so we need to work together to keep our kids healthy and active and get them back to sport in the safest manner possible. Thank you for your time.